Hi, good evening, Dr. Munish.
Good
Can you hear
evening.
me?
Hi, Srinivas.
Right, thank you.
Welcome.
So डॉक्टर जी प्लीज चेक YouTube लाइव।
अभी YouTube लाइव चेक कर रहे हैं, तुम्हारी लिंक चेक कर रहे हैं। तो अपन मीटिंग में हो क्या?
अजय, मैं DIAP से करवा ले रहा हूँ, मैंने बात कर दी।
हाँ, YouTube लाइव हो गया है सर।
अच्छा, हो गया?
हाँ, हो गया है, बस इसका चैनल को वो सब जगह भेज दें एक बार। इसका लिंक जो है, लिंक शेयर कर दीजिए शर्मा जी। उस लिंक को जो है ऊपर में लिखा हुआ है, सबके लाइव YouTube लिखा है ना, वहां पे अगर क्लिक करेंगे तो आपको इसका लिंक मिल जाएगा और उसी लिंक को शेयर करना। अभी अलग से चैट बॉक्स में डाल दे रहे हैं।
नहीं तो अब मेरे को कुछ नहीं करना ना?
आपको कुछ नहीं करना है, आपको खाली ये करना है कि जो लिंक आपको भेजेंगे वो एक बार DIAP को बोल दिया कि सबको भेज दे, मतलब जो ग्रुप है। वैसे कुछ नहीं करना है, कर देते हैं, उसको भी कर देंगे, अभी कर देते हैं।
चलाना थोड़ा सा।
डॉक्टर श्रीनिवास सर और डॉक्टर जुल्फिकार सर, आप लोग अपनी स्लाइड एक बार चेक कर लीजिए जल्दी से।
Can I share now? Just see what is happening.
Yeah, I am trying to share now. Host is disabled.
शर्मा जी, इनको डॉक्टर श्रीनिवास सर को एक्सेस दे दीजिए।
हाँ सर, एक मिनट।
अभी डॉक्टर जुल्फिकार सर का हो रहा है।
Zulfikar sir is doing. I'll do it after that.
And मुझे भी दे दीजिए।
You can see that?
Yes,
Yes,
yes, yes.
Okay. So I will switch back to stop sharing, right? Okay, thank you.
तपन एक सेकेंड के लिए ये जो आपके पास लिंक आया है ना चैट बॉक्स में, इसको हर जगह डाल दीजिए, YouTube लाइव लिंक को।
ओके सर, मतलब
सारी जगह जहां जहां हम लोग का है हर जगह डाल दीजिए।
ठीक है, ओके सर।
आप ट्राई कर लो शेयरिंग।
हाँ, आप ट्राई करो।
जो व्हाट्सएप ग्रुप बनाया है उसके लिए, पार्टिसिपेंट्स के लिए, उस ग्रुप में डाल दिया है मैंने वो YouTube लिंक।
और नहीं, इसके अलावा जनरल डाल दो, अपना LAP पे UPIAP हर जगह डाल दो।
ठीक सर, ठीक।
Srinivas, check your sharing.
I'm still not able to share.
शर्मा जी, शर्मा जी इनको अलाउ कर दीजिए, डॉक्टर श्रीनिवास को।
नहीं, he can share.
No, host disabled participants screen sharing is a message.
No, he is not till now. He is not co-host. No, make him co-host.
उनका यूजर नेम क्या है?
श्रीनिवास लक्ष्मी वेंकटेशिया।
Okay, done.
Done.
But
Okay, sir, please check.
Yeah, I'm sharing.
Is not restricted.
Yes, yes. Yes, sir. It's getting. It's fine. You can stop it now. Thank you. So इसको अब हम लोग रिकॉर्डिंग में ले जाएं। शर्मा जी, रिकॉर्डिंग स्टार्ट है ना?
Yes sir.
अब से स्टार्ट कीजिए। अभी के पहले वाला को रोक करके फ्रेश स्टार्ट कीजिए। ओके, डॉक्टर मुनेश, आपका भी स्क्रीन शेयर हो रहा है?
Yeah, I've done. I keep this.
Okay, so we are going to start now. You please stop your share. So hello and welcome to this hybrid certificate course from AOP UP, that is Academy of Pediatrics UP, that is ECG for Pediatrics, in association with Fetal Cardiology Forum and offline support by Lucknow Academy of Pediatrics. I, Dr. Ajay Srivastava, Secretary of AOP UP and Course Coordinator, welcome you all. I proudly share with you all that this is already a super hit program with more than 200 paid registrations. At the time when we would have been very satisfied with 50 only. So also probably this is first ever program in UPIAP history where we have 10 delegates from overseas like Fiji, Bangladesh and Sri Lanka and from many other states. And this is all due to sheer fame of our expert faculties from all over countries. Dr. Srinivas from Mumbai, Dr. Julfika, Dr. Dipti from AIMS, Dr. Anil Singhi from Kolkata, and all other stalwarts. So, have been put under umbrella of AOP UP by our lead coordinator, Dr. Munesh Tomar. She is senior pediatric cardiologist from Meerut, and she also deserves a huge round of applause. And before I proceed, I would like to invite President AOP UP, Dr. Alka Agarwal, for official welcome note.
Thank you very much, Dr. Ajay. And it's indeed a very proud moment for Academy of Pediatrics, Uttar Pradesh, for holding and even initiating such a program of doing a certificate course in ECG, which is a very, very important course to be taken up. And though it is not a part of the curriculum, but as an extension of our curriculum, it will be an extremely important thing for our postgraduates as well as other practitioners to learn. And I'm greatly indebted to the efforts of the faculty which is there from all across the country. Dr. Zulfikar is there, Dr. Munish Tomar, who has coordinated, then the Lucknow Academy of Pediatrics team led by Dr. Abhishek Bansal, and everybody who has contributed to the success of this program, because 200 plus registrations, paid registrations, means a lot for us also, as well as it speaks for the volumes for the credits that it's going to earn. So thank you very much. I have all my blessings for the program, and I give it back to Dr. Ajay. Thank you very much.
Thank you, Dr. Alka. And it's a matter of proud privilege for us that we have been blessed by presence of our HSC CIAP, Dr. Vinit Saxena sir. I request him to say a few words of blessing. Dr. Vinit Saxena sir.
Thank you, Ajay. Dr. Alka Agarwal, President AOP UP, Dr. Ajay, and many stalwart of cardiology chapter, our beloved Julfi sir, Dr. Munesh, Manisha, and Srinivas, and many more whom I cannot recognize on the screen. So this is really a milestone for IAP, because you are coming with vision of president that chapter should work for IAP members. Kya ho raha tha? Chapters were working like a classical music artist, that they play something and only people knows that they enjoy. But doing something for ordinary IAP member is something great, and it really matches aims and objectives for IAP. And in the next step, we have to go to the community by directly communicating to the community. So this is a very wonderful course. Faculty is best in India, and content is really good. And I was trying to bring it under umbrella of ICP, but Dr. Munish tried but the time was very short, and there was a system of approval from Dean and Academic Council. So I request Julfi sir, Dr. Munish, आप इतना बढ़िया काम कर रहे हैं, तो इसे brand दो आप ICP का, and we will promise to give all sub-technical as well as logistic support from IAP. My best wishes to LAP and cardiology chapter for bringing such a wonderful program. Thank you.
Thank you, sir. And let us start our program with lamp lighting ceremony. Okay, so. Just 1 second. Just 1 second. I'm sorry.
कल्याणम् आरोग्यं धन शत्रुबुद्धिविनाशाय दीपज्योति नमोस्तुते दीपज्योति नमोस्तुते। इस दीप को प्रज्वलित करके हम सारे वातावरण को शुभ और कल्याणकारी करें। इस दीपक की ज्योति से सारे शत्रुभाव मिट जाए। इस पावन दीप को हमारा नमस्कार।
So thank you all and wishing you all best of learning times. I now invite our lead coordinator and program in charge and hands behind this program, Dr. Munesh Tomar, to take charge from here. Dr. Munesh.
Thank you. Thank you, sir. I'm going to share from my screen. Very good evening, everybody, and very warm welcome to this important activity, actually, ECG for the pediatrician. We all are very much into ECG, but for the pediatrician, they feel a bit nervous when too much of variation in the heartbeat they find, and they obviously refer to us. And why it is important? Because we all know that ups and downs in life are important to keep us going. And a straight line, even in an ECG, means we are not alive. So we need to have those ups and downs, and these ups and downs in ECG convey a lot to us. Going towards a little bit about the history of the ECG, it started in 1842 when a first from the frog. It was work of all the physics people, related to physiology only, who have worked on the ECG, development of the ECG. The first was in 1842 from a frog heart. And then in 1901, 3-lead ECG by Antoine, he got Nobel Prize for that. Then we got precordial leads in 32, 38. And then finally in 1954, when AHA standardized the 12-lead ECG. And from that only, means now this is 70 years, the same ECG we are using, and that 70 years ago, everything standardized with some modification in the machine and techniques only in artificial intelligence. But what basic thing we are having for last 70 years. This is the first ECG recorded from a human heart from anterior-posterior leads. This was taken by Waller. So from there, now we have 12-lead ECG, 15 ECG, and the 17-lead ECG, depending on our needs. So lots of modification happened over the ECG, and today it provided a lot of information when we think from the cardiology point of view. Why this is important? Because there is lots of development in imaging. We have a wonderful echo machine, 3D, 4D, we have CAT, we have CT angio, we have cardiac MRI, but the basics of the evaluation, like that tripod, we should never leave this tripod. That is clinical evaluation, chest X-ray, and ECG. If we focus on that, as a pediatrician, we focus on that, we can pick up more than 90% of the cardiac ailment in a child, any patient coming to you. So this form the main tool for evaluation of these kids, for suspicion, for detection, and then obviously you refer the patient to the higher, depending on the specialty, subspecialty. So ECG today we are going to cover on the ECG, and then subsequently we will go to the further more modalities on follow-up as development of this subspecialty. So to start with ECG, our first opening batsman is Dr. Srinivas. He's from Thane, Maharashtra, and he's like one of the pediatric cardiologists doing all critical interventions. Very good interest in ECG in clinical practice. Same way he's in echo, fetal echo, cardiac interventions, everything he's doing. Very wonderful job he's doing. He's writing chapters, writing books. So Srinivas is doing a very great job from pediatric cardiology point of view. And today he's going to speak about the basics of ECG in a child with cardiac issues. So over to you, Srinivas.
Thank you, madam, for an excellent introduction to ECG and a little bit overrated introduction to me. So let me share my screen. Okay. And a very good evening and a warm welcome to all the delegates. I'm very happy to see Zulfikar sir, who has been my teacher from Amrita days. A very loved teacher by all the students, who is known to make the subject very simple. Good evening, sir, and all the dignitaries from Uttar Pradesh IAP. Wonderful people. Nice to meet you all. So without wasting much time, let us start with today's topic. So as you have seen, today I'm going to talk about this. Sorry, I think I selected the wrong one. Yeah, I think you are able to see my screen. So today my topic is basics of ECG. Okay, so it's not ABCD of ECG, but PQRSTU of ECG. So Madam was just explaining about the history of ECG. That's so wonderful, ma'am. So initially when Valor started with doing ECGs, this was how it was looking like. The ABCD nomenclature that you are seeing in my screen is from Valor. So once William Anthoven started doing an ECG, he refined this ECG technique, acquiring of ECG techniques, then started the first point. So P is just a random point on the graph. So he named it as P and then followed all the positive and negative waves as PQRST. So basics itself is so interesting in ECG. So today we are going to learn about PQRSTU of ECG. Okay, this was the tripod that Madam was trying to say. Let's try to fortify the ECG tripod. If anybody wants to know about the basics of the ECG, there's a wonderful article in circulation you can all go through. But today we'll stick to more of learning of basics of ECG as relevant to a pediatrician. As a pediatrician, if I sit in the clinic and see what are the indications of ECG in today's era, so I would say abnormal rhythm would be the most common reason why I want to do an ECG. It could be a tachycardia, it could be a bradycardia, or it could be just irregular heartbeats, which is by far the most common reason why pediatricians do an ECG. The next most important clinical utility for ECG is in diagnosis of cardiomyopathy. Believe me, a large number of cardiomyopathies can be diagnosed with the help of ECGs. So whenever you ask for an echo or you get an abnormal echo report, please also ask for a ECG to be done. So without doing an ECG, do not label any child to have cardiomyopathy. This is the second most important clinical utility in today's era of echocardiography. So chest pain, yes, it's most often done ECG in a chest pain, but the diagnostic yield is low. But most of the times the ECG is done to reassure both the child and the parent and to document normalcy of ECG. Diagnosis of CHD, it has assumed fourth position in my list because echocardiography by far more or less replaced a diagnostic tool of congenital heart disease. ECG is only a supportive tool for diagnosis of congenital heart disease. Electrolyte abnormality, again, in presence of excellent machines to analyze electrolyte abnormalities, one need not wait for the ECG changes to happen to diagnose electrolyte abnormality in today's era. But it's good to have knowledge of ECG and pattern recognition of which electrolyte abnormality causes which pattern of ECG. So this would be the ECG or relevance of ECG in today's pediatric cardiology or pediatrics practice. So what do I cover? I'll cover very, very basics today. I'm not going to talk about the whole thing. So I'm going to tell you how to obtain an ECG in a child because I think this is a very important practical point for all of you. I'm going to decipher different components of standard ECG. I'm going to talk about very briefly practical aspects of basic electrophysiology. And I'm going to conclude my talk with saying what is normal in a child. Okay, so this is the most important topic for today's delegates gathering here because one of the most common reasons for not doing an ECG among my pediatric friends is they do not have equipment. This is the most common complaint that I've heard from each and every pediatrician who send a patient to me. So they say we do not have pediatric specific equipment. Second is, yes, of course, this is a serious limitation because as pediatricians, we do not get so much of training in reading ECG in our undergraduate days. And many of cardiologists, even adult cardiologists, are not aware of normal variations of the ECG. So because of all this, there is a lot of hesitancy in getting an ECG in a child. Okay, so this is the evolving of ECG machines, right from a string galvanometer, what was used by William Anthoven, This is more or less the present standard equipment that we are using in most of the hospitals. You also have a few handheld equipments which can reasonably give graphs, and even there are wearable devices which can record an ECG. Of course, for clinical discussion, we are only concentrating on this standard equipment of ECG. So how do we obtain an ECG in a small child or an infant? Okay, so I said the first problem is lack of pediatric specific equipment. So this is the photograph of our ECG machine in Jupiter Hospital. This is a standard adult echo machine. We do not have any pediatric specific equipment. But once we remove this bulbs here, okay, which usually go on the chest and also this cuffs here, this becomes a pediatric specific equipment. Okay, how does it work? So now this is a small neonate who is having actually atrial fibrillation. So we have attached defib paddles for doing a DC cardioversion. You notice that these are the ECG electrodes that is attached to the limb of the child. We have removed all the suction cups. We have just attached this directly onto the skin of the child with some jelly and using a micropore tape. So this alone is enough to give a good undisturbed ECG even in a very small child. Okay, so this is one of the post-operative child whom we are trying to do an ECG. This child must be 3 years old. So look at how we have attached the chest leads. We have removed the suction cups and we have attached the electrolytes directly onto the skin using some electrolyte jelly using a tape. So you can say that this is a jugadu, but this is what actually is most commonly available, and this works 99.999% of the times. And I have not seen that 0.0001% because this is what we do on a routine basis. So henceforth, please do not stop yourself from doing ECG just because you don't have an equipment. So you can do a beautiful ECG even with normal standard equipment. Lead positions is not rocket science. Usually it is written in most of the ECG equipment itself. You just have to place limb leads and also chest leads as per the instructions given on your ECG machines. So this is not a reason for not doing the ECG at all. Now let's understand the very basics of electrophysiology. So this is a artist impression of electrical conduction system of the heart. So this is how the electrical conduction system is supposed to work. Actually, you will never see this in gross specimen at all. This is just an artistic impression. If you say that this is the place where your electrical activity starts, this is sinoatrial node. From there, the impulses are transmitted through the atria, AV node, then through his Purkinje system into ventricles. Okay, so this is an electrical conduction system of the heart. So when we record an ECG, this is what actually we get the display. So in this, you can see there are various components of this ECG designated as P, QRS, T, and U wave. Okay, so the interval between P and QRS is the PR segment. Interval between the QRS and T is called as an ST segment. Okay, so this is displayed in a graphic format like this. So each ECG complex is composed of this graph. Okay, these are the consecutive graphs in a child. So each complex will represent a heartbeat like this. Okay, so the height of this activity, height of this graph is the voltage and the duration is the time. So it is a time voltage graph of electrical activity of the heart. Okay, so what does each graph mean? P waves just mean sum total of electrical activity. Both left, right atrium, both put together will cause a P wave. Then the time taken for the impulse to travel from the sinoatrial node to AV node is represented by PR AV nodal interval or PR interval. Okay, so that is the first interval after the P wave. So next is the QRS complex. So that is the definite positive sharp upstroke and downstroke that you see. So this is the sum total of electrical activation. Okay, so once that is done, then you have something called a ventricular repose. That means this is the recovery of the ventricles after contraction. So this is the electrical representation of the recovery of the ventricles after the contraction. Okay, so these are the components of an ECG. P wave followed by PR interval followed by QRS complex, then ST segment and T wave. Okay, so once you get a 12-lead ECG, this is how the ECG looks like. Okay, so many crooked lines, right? So let us just simplify this and see what are the components. Before reading any ECG, notice this number. So here there is something called as the paper speed, and this is called as a ventricular, standardization of the ECG. Okay, what does it mean? The paper is running at 25 millimeters per second. So this is the world standard of taking an ECG. You can increase or decrease the speed, but remember, when you read an ECG, you should have a standard 25 millimeter per second ECG. So what is the standardization means? If you see this small box-like thing before every ECG, so this is 10 millivolts. That means 10 millivolts is represented by 10 small squares on the ECG. That means it is standardized. Let us say if I take 5 millivolts standardization, that means the complexes would be double this size. Okay, so make sure that you are getting an ECG to read, which is 25 millimeters per second speed and which is 10 millimeter volt. Okay, so this is one of them. So once you get this graph, there are various components. Okay, so here there are total 12 leads. Okay, 1, 2, 3, 1, 2, 3, 1, 2, 3, 4, 5, 6. Okay, there are totally 12 ECGs in this. Advantage of taking a 12 lead ECG is that all the graph is recorded simultaneously. Okay, that means each beat is recorded. For example, this V1, same beat is recorded here, same beat is recorded here, same beat is recorded here. Okay, all of them will give the different electrical phase of heart in the same beat. That's the advantage of taking a 12 lead. When you do it in a single channel ECG, every beat represents a different heartbeat. So there is no 100% correlation. That's the reason why we have to do a 12 lead ECG. Okay, so out of these 12 leads, I have labeled 3 as bipolar leads. So what are bipolar leads? Bipolar leads are 1, 2, and lead 3. I'm going to show what is bipolar, what's the meaning of it. And there are 3 augmented limb leads. That means there is one AVR, AVL, and AVF. So these are unipolar leads, but they are augmented. Then you have 6 chest leads, which represents the surface electrogram, mostly of ventricles. But yes, you can also see the P waves. Okay. Of course, as I told you, there can be multiple variations. You should always make sure that you're reading a standard ECG. Okay. So what is bipolar? What is unipolar leads? I said bipolar leads will have 1 negative, 1 positive, 1 positive, 1 negative, 1 negative, 1 positive. Okay. That means lead 1, 2, and 3 are called as a bipolar leads. AVL, AVR, and AVF is called as augmented limb leads. Okay. These are all the bipolar leads and these are the augmented limb leads. So why do we do this? Because we are recording the electrical activity of the heart like Earth's magnetic field in 6 different planes. Okay, so that I can get an overall 360-degree view of the electrical axis, electrical field of the heart. Okay, so I can interrogate the electrical field of the heart in different degrees. Okay, if I divide all these things into 6, 1, 2, 3, 4, 5, 6 planes cutting, what you get is called as hexaxial system. So I can look at the heart at 0 degrees, minus 30 degrees, 60 degrees, 90 degrees, and vice versa. Okay, I can interrogate the heart in various angles. That is called as hexaxial system of the heart. We will take a few examples, then you will understand it more easily. Whereas the chest leads are directly on the chest wall. Here you have V1, V2, V3, V4. These are intercostal spaces. This would mostly indicate what is happening with the progress of the active electrical activity from right ventricle to the left ventricle onwards. Okay. So if let us say if you have heart here, so it first records the right ventricle, septum, left ventricle, and the left ventricular apex. It records the electrocardiogram of the ventricular mass mostly. Of course, you will also see the atrial activity also on a chest lead. Okay. So now over the next 5 years, I think most of you will go through all of them. Today, I'm not going to cover everything. So, but this is how an ideal ECG report should look like. A clinician should aim to give a complete report of the ECG based on all these 10 specific points. So today, under the basics, I'm going to cover how to report heart rate, rhythm of the heart, axis of PQ and T wave is what I'm going to cover. This is by far the most simplest of the ECG measurement. So this is calculation of heart rate. There are 3 methods. So these 2 are standard methods. Look at number of small squares between the RR divided by, 1500 divided by number of the small squares between the RR, or divide 300 by number of large squares between the RR. I'm going to show an example. And of course, you have an easy method also. So what is the easy method? So these are all the small square and there will be a large squares. What is the easy method? You just have to remember this sequence of number. What is this? 300, 150, 100, 75, 60, and 50. So once you remember this sequence of number, you see what is the number of large squares between the 2 RR intervals. Okay. If it is one large square like this, the heart rate is 300. If the distance between two RR is 2 large squares, the heart rate is 150. 3 large squares, 100. 4, 75. 5, 60. Okay, in this patient, the number of large squares between the two RR intervals is 5, so the heart rate is 60. So if you just remember this sequence, you can very quickly, within fraction of a second, calculate the heart rate. So this is what most of the electrophysiologists do to calculate the heart rate. For example, I'll just put up an ECG. So quickly you can type or you can say what is the number of large squares and what is the heart rate in this child. So I'm just going to give you a few seconds to do that. Okay, so compare two RR, 1 and 2 RR intervals. How many large squares and what is the heart rate? I can see 1, 2 large squares. So what is the heart rate? Okay, so 150 is a heart rate. Okay, so let us see the next example. Okay, so because it's an online program, I will not be able to see your responses so quickly. So I'm just going to assume that all of you are attempting this. Okay, so in this ECG, how many number of large squares are there between the two RR intervals? Hardly one. So what is the heart rate? 300, right? Okay, how about this one? So how many large squares? Okay, so what is the heart rate? 1, 2 large square. What is the heart rate? 300. No, 150. Okay, so that is how you calculate the heart rate quickly. Okay, so as I told you, the proper method is divide 1500 divided by number of small squares or 300 divided by number of large squares. Okay, so one more last example and then we'll go to the next aspect. What is the heart rate? How many large squares? Less than 2, isn't it? So heart rate is anything between 150 to 200. Okay, so that's how you quickly determine the heart rate on a given ECG graph. So the next important topic, let us come to electrical axis of the heart. I know it is one of the very scary topic, but I would make it as simple as possible so that after today, any pediatrician will be able to comment on what is the axis of the heart. Okay, so I've showed you two pictures here. So the left one is a cartoon with a heart. Okay, the right one is Earth with its magnetic axis. Okay, so you know that Earth is a magnetic axis. Can we see this axis? No, we cannot see this axis, right? But we all know that there is a magnetic axis of the Earth. Okay, that means it is a net polarity of this magnetism of the Earth. Okay, which has a North Pole and which is South Pole, and this is the direction of that. Exactly in similar fashion, because the heart is within the chest of an individual, it also exerts an electrical axis. Okay, so what does it mean? In a heart, so the activation of impulses starts from the base of the heart here and proceeds towards the apex of the heart. Okay, so if this happens, then there is a vector of this electrical activity. Okay, so axis means what is a vector of this electrical activity or what is a net force of this electrical activity. In this cartoon, I have shown you that the vector is like this. Okay, so exactly same way, the normal vector of electrical axis of the heart is between 0 degree and 90 degrees. Okay, this green square represents where the electrical axis of the heart is situated. For example, if the patient has a dextrocardia, the electrical axis will be on the right side, right? So that is just an example I'm telling you. I'm going to take you through this. Okay, so if somebody has not understood this or they need time to understand this, okay, there is nothing lost. Okay, so next I'm going to give them a thumbs up challenge. Okay, in this challenge, within next 1 minute, I'm going to make you all experts in reading electrical axis. Okay, so this is my challenge. This is not your challenge. This is my challenge. Okay, are you all ready for the thumbs up challenge? Okay, to thumbs up challenge to work, I want all the delegates to use 2 thumbs like this. Okay, can you see my thumbs? Okay, so use left hand and right hand, left thumb and right thumb. Okay, so once you have, just keep it in front of you. See your own hands with your eyes. Okay, so use your left hand for lead V1. Use your right hand for AVF. Okay, so we need only 2 electrodes to determine the axis of the heart. Okay, don't look at anything else. Just look at V1, lead 1 and AVF. Lead 1 and AVF. 1 for left hand, AVF for right hand. Okay, so once you do this, calculate what is the total voltage here. Okay, so if the total voltage is up like this, it is positive. If the total voltage is down like this, it is negative. Here, the net voltage is mostly positive. Okay, that means my thumb will be up. Okay, and the net voltage here in this one is negative. So my thumb will be down like this. Okay, so easy. Net voltage, just point your finger. Okay, so negative voltage down, positive voltage up. Okay, so once you do that, next point is determining the axis. Okay, so if net voltage in both 1 and AVL is positive, that means my left and right thumb is up, it is normal axis. Both thumbs up, normal axis. Okay, so right thumb is down, left thumb is up. The axis is left axis deviation. Okay, so it is the other way. My left thumb is down, right thumb is up. The axis is right axis deviation. Okay, so the last one, both of them are down like this. This is also possibility, right? So it is indeterminate axis. Okay, you have only 4 possibilities: normal, right axis, left axis, indeterminate axis, and you have to use only lead 1 and AVF. Okay, let us go to the example now. So this is the example that I showed you in the beginning. So quickly use both your thumbs. Okay, so you tell me what is the axis of this patient. Okay, so my left hand is for lead 1 and right hand is for lead AVF. Okay, here AVF is positive, so my right thumb will be positive, it will be up. Here lead 1 is negative, so my left thumb will be down. Right, so what is the axis of this patient? Right axis deviation. Okay, I think most of you have got it right. So now in this ECG, what is the axis? Again, use the same thumb phenomenon. Okay, so AVF and lead 1. Lead 1 is positive in this child, AVF is negative in this child. So what is the axis? Left axis. So this child has left axis deviation. Okay, how about this? Now this is lead 1 and this is AVF. Okay, this is a 6 lead disease. This is not a 12 lead disease. That's why this is 1 and this is AVF. Okay, so what is the axis? Let us suppose this is negative. Okay, lead 1 is negative and this one net voltage is negative. Okay, what is the axis? So it is indeterminate axis. Okay, so I think this will be the last example. What is the axis in this child? So the net voltage of lead 1 positive, net voltage of AVF is positive. So what is the axis in this child? Normal axis. Okay, so this is normal axis. Okay, both of them positive. Okay, so we have with the thumbs up challenge, we have 4 situations. Okay, so both up, normal axis. Okay, so left axis, left up, right down. So right axis, right up, left down, and both down is indeterminate axis. Okay, so there is a lot of physiology behind this. If you see this x-axial reference system, so this is your normal axis, left axis, indeterminate axis, and right axis deviation. Okay, it has a very sound physiological phenomenon to axis determination. So axis determination is that simple. Okay, it is not at all difficult. Okay, once you know how to determine the axis, what is the interpretation of this? Okay, so if both are positive, axis is normal. So normal axis is abnormal in neonates and early infancy, but normal axis is normal only in a child after the age of 3 to 4 years. Remember this. You have a neonate with normal axis, it is abnormal. Okay, you have 1-year-old child with normal axis, it is abnormal. You have a 4-year-plus child with normal axis, it is normal, right? You have a right axis deviation in a given ECG. This is normal in neonates and early childhood, which is between 3 to 4 years. By around 4 or 5 years, this axis is going to become like an adult and resume normalcy. Okay, if you have any deviation in these 2 things, the ECG is abnormal. Whereas left axis deviation, gross left axis deviation at any age is abnormal. Okay, northwest axis is abnormal at any age. Okay, this is how you use the information of diagnosing axis of the heart. Okay, right. So far we have covered heart rate and axis. So let us see what are the normal values. These normal values, no need to take it down because I have taken it out from your PALS courses. Okay, so your PAL says these are the normal values. Okay, so you can get this reference readily. So remember that out of all these things, QTC is very important thing. Always calculate QTC and by Bazit's formula. So less than 440 to 460 is normal. More than 460 is abnormal in any patient. Okay, so now we are able to do a proper 12-lead ECG respective of age. We are able to identify PVS and QRS complexes. we are able to determine the axis and we are able to determine the heart rate. I think so far so good. Okay. So now let's go to somebody is actually drawing some crooked lines more than ECG. So if you can delete them, it will be nice. So what is normal sinus rhythm? Okay. So this looks very nice, isn't it? So it looks like a normal sinus rhythm, but electrically defining what is normal sinus rhythm. To call any patient as having normal sinus rhythm, patient should have normal p-axis. Always remember, we tend to overlook p-axis in a child. So always remember, you have to look for p-axis as you look for QRS axis in the same way. Each p wave is followed by a QRS complex. There is constant PR interval. This interval has to be fixed. There cannot be any variation of few milliseconds also here. Okay. And the heart rate should be within acceptable limit for age. It should not be bradycardia, it should not be tachycardia for that age. Then you call this normal sinus rhythm. But to call an ECG normal, you need a little bit more interpretation than just a sinus rhythm. As I told you, P wave is upright in one AVF, normal P axis, QRS axis. Each P wave is followed by QRS complex. And on top of it, make sure that the morphology of P wave, PR interval, QRS duration, all these things are also normal. Okay. Once you've decided that all of them are normal, then you give a report of normal ECG. Okay. So I think I've come to the last part of my talk. I'm going to talk to you about a few normal age-related changes. What is abnormal for what age? Then I'll conclude my talk for today. Okay, so as I told you, newborn babies will have right axis deviation with right dominance. Okay, if they have normal axis, if they have left axis, they are abnormal. Okay, remember this. There is dominant R wave in V3R or V1, which can be persistent up to 6 months to 8 years. That means a positive QRS complex in V1 is normal for any child from 6 months to 8 years. Okay. In majority, this pattern will change by 4 years. That means the R wave will become less prominent, S wave will become more deeper by the age of 4 years. Okay, so T in V1, very important. Okay, just remember V1. Don't worry about what is V3R. It's a right-sided lead. Okay, just remember V1. T in V1 is inverted by 5 to 6 days of life. Okay, it should not become positive before 6 to 7 years of. Okay, if T wave is positive beyond 7th day of life in a unit, that means it indicates significant right ventricular hypertrophy. Okay, so up to 6 to 7 years, you never see a T wave which is upright in a normal child. Okay, adults also can have T wave inversion beyond the age of 7 years. That is called as juvenile T wave pattern. Okay, Q waves are normally seen in lead 2, 3, and AVF. Okay, so do not diagnose them as having myocardial infarction. Okay, most of the congenital heart diseases also have Q counterclockwise loop. So this is what I mean to say. There are tiny Q waves in this lead 2, 3, and AVF. What is the definition of tiny? It should not be more than 1/3 the size of the preceding QRS complex. That is normal. If it is more than 1/3, it indicates ischemia or infarct. Okay, so this ECG's QRS complexes, you can have a small negative deflection here in 2, 3 AVF. That does not mean that the child has ischemic heart disease. So counterclockwise loop is very unusual. Most often it is associated with heart disease. What do I mean? Counterclockwise loop means there are Q waves in 1 and AVL instead of 2, 3, and AVL. Okay, so this is abnormal. Okay, so atrial ventricular extrasystoles are quite common in child. Especially, remember, they are always associated with slower than normal heart rate. Okay, so it is quite common to have atrial extrasystole or a PPC or a APC, atrial premature contraction or ventricular premature contraction. So to be sure that they are benign, you ask a child to do a little bit of an exercise like running, climbing stairs, jumping, doing sit-ups, and then repeat an ECG. When the heart rate increases, they all should disappear. Any of the extrasystoles or irregular heartbeats that disappear with exercise is abnormal. They do not indicate heart disease. Okay, so there is something called as early repolarization. I think I'm just going to show you an example. I'm not going to go through each and every word. Here, what you're seeing is there is uniform elevation of the ST segment with an upright T wave in all of them. Okay, so this is a normal pattern. It is called as early repolarization abnormality, typically seen in leads V1, V2, V3, and V4, and sometimes in the limb leads as well. Okay, so they are not examples of ischemia. Okay, So ST segment elevation with the terminal T wave inversions, combination of early ripple persistent junior T wave, all of them are normal. Okay, so this is another example of the same. So sinus arrhythmia, very, very common in general practice. So what is sinus arrhythmia? So because the AV node is subject to the vagal stimulation, so patients with little bit hypervagotonia, they will have irregular heartbeats. If you see, is it a normal rhythm or not? Yes, it is a normal rhythm because P wave axis is supposedly normal. PR interval is fixed, but there is irregular heartbeats. This happens with because of respiration. Okay. Again, sinus arrhythmia is usually gone if you make this child do a little bit of an exercise. With increasing tachycardia, vagal tone is gone and patient will have regular heart rate. Okay, this is another way to test whether it is sinus or non-sinus. Again, this child also was referred for the same reason. Again, you say you have this child has more than sinus arrhythmia. This child also has early repolarization abnormality. Okay, this child did not have any heart disease. Okay, so in a sinus arrhythmia, PR interval, PP interval varies, PR interval is fixed. Okay, and correspondingly RR interval also. That means patient will have an irregular heart rate with a constant PR interval. Another very important point that you need to see in a patient with who comes with ECG is a QT interval. QT interval can be varying in first 3 days of life. Usually it settles after 6 to 7 days. So if you diagnose abnormal QT interval in a unit, I would rather ask you to do a serum calcium level in that child, see the ionic calcium levels. If they are normal, not to do anything, just repeat an ECG after 7 to 10 days. QT prolongation of more than 0.45 seconds warrants further investigation in any child. Rule out all these electrolyte abnormalities. Keep in mind, one of the very common modality of presentation of congenital long QT syndrome is bradycardia in a neonate. This bradycardia happens because of relative heart block because of the prolonged QT interval. Okay, always in any ECG, please read please report QT interval also. Okay, so this would be the last slide of my topic. As I told you, there are still many things to be covered in an ECG. Subsequently, next 5 days, you have a galaxy of speakers. Many of them are my teachers, my colleagues, excellent speakers. I congratulate Punesh Madam for having chosen all the stalwarts in this specialty. And I'll be eagerly waiting to hear from Zulfikar sir. And I would conclude my topic here. I can take some questions if anybody has a question.
People can type in chat box and then we'll take all the questions at the end of session. Thank you, Srinivas. I think the basics cannot be beautifully explained than this, what you have explained. Very simply, simple form, all basic things which pediatrician or anyone, intensivist or residents or nurses. So these basic things explained very beautifully by Srinivas. And if anyone has any query, just please type in the chat box. We'll try to answer at the end of the session. Now the next speaker is Professor Zulfikar. Sir doesn't need any introduction, very senior pediatric cardiologist. He's former professor and head from Government Medical College, Trivandrum, and so many like long series attached to sir. And like in clinical classes, sir is a regular in NB webinar. All students enjoy the way he explained the pediatric cardiology to the students, whether it is cyanosis, whether it is murmur, whether it is X-ray, or now this is ECG. So, sir, now it is to you. We all are very eagerly waiting to listen to sir.
Can you see the slide now? Hello? Can you see the slide now?
Yes, sir.
Yeah, sure.
Yes.
Okay, fine. Thank you. I think, see, what I learned from Srinivas is that the wonderful way of simply representing the QRS axis. I think that is one very interesting thing which I have learned from Srinivas. Thank you. And last week we in Kerala celebrated the greatest of all festivals in Kerala, that is the Onam. My Onam greetings to all of you. This is Mahabali. He is a very handsome king. And this basically represents the images of Onam, the Mahabali, the food, the Ookalam and all. And today, after Srinivas, I will discuss the reading of an ECG. There could be some overlap in between Srinivas and myself, but we will manage that. Now, this is an article from circulation, a historic ECG from the past. This was a 70-year-old man, not pediatrics, who had uncontrolled hypertension for 220 by 110 millimeter of mercury. In addition, he has been noted to have fullness of neck veins and pedal edema in the past. And this is the ECG of that gentleman. And this ECG is particularly important, not because it shows some a different kind of ECG than what we see today, but because this ECG belonged to a very greatest person who ever lived in our country, that is Mohandas Karamchand Gandhi. So, and of course, he is the person who we must all. Now, chest X-ray is basically a structural window to the heart, whereas an ECG is an electrical window to the heart. So that's the basic difference between an X-ray and an ECG. And always, as the Bard says, past is the prologue. So we must have a little bit on past, which I already, Munish has mentioned, starting from the electrical current from a frog heart, and finally ECG recorded by the string galvanometer, and finally culminated in the Nobel Prize awarding to Eindhoven. And we must definitely pay homage to Eindhoven, who died only 3 years after he got a Nobel Prize. And these are the contributions of this particular gentleman: the term electrocardiogram, the PQRST labeling, the 3 peaks, the 2 troughs, and the Eindhoven triangle, which we already know. This has already been shown to you by Srinivas. Now, so the second part of ECG reading, the first part belonged to Srinivas, and this would be the second part. Now, why should we take an ECG? We know, basically, look at the structural heart disease, electrical diseases, and the structural heart disease could be acquired or congenital. And there are so many classifications of this particular thing. We must, so everywhere ECG is important, but in some certain areas like Srinivas mentioned, that is probably more important than many other investigations. So in a structural heart disease or a congenital heart disease, what we want to know is the relative involvement of the chambers, presence of pulmonary hypertension, any arrhythmia substrate, or a severity of a particular congenital heart disease. Now, the point in ECG is that it need not be always diagnostic. Once in a while, it can be diagnostic, like in a blue baby with a tricuspid atresia. It can be more or less affirmatory in a blue baby with a tetralogy of Fallot. It can be supportive of our provisional diagnosis of an atrial septal defect. So it need not be always diagnostic. And we should also know that there are changes occurring from day 1 onwards, and the major changes occur in the first year of life. And a very practical thing we must remember, that especially when people take newborn ECG, the computerized system of measuring various intervals, including QTC, can be inaccurate in the newborn baby. So we must give some allowance for that also. And this is there are 5 ECG waves, as you know: P, QRS, T, TA wave, which is not seen, and the U wave. There are 2 ECG intervals. Again, we know that PR interval and the QT interval, which Dr. Srinivas mentioned. And we have three segments, a PR segment, an ST segment, and a TP segment, which is considered as a baseline segment. Now, in infants and the newborns, we usually take a 12-lead ECG with additional V3R, sometimes even V4R, because that may face the right ventricle because the heart is a little more horizontal in a small baby. And when you suspect a dextrocardia, we should take leads from V3R to V6R. That is very, very important. And if you want to analyze a suspected arrhythmia, we should ask for a rhythm strip or a long lead 2. Usually long lead 2 also has to be ordered or asked or requested from the technician. And this, I think, this what I used to call as a 10 commandments have been already described by Srinivas, starting from the heart rate, rhythm, P wave, PR interval, QRS width and morphology, QRS axis. So elegantly put by Srinivas, R by S in V1, V6, ST segment, QTC, and G wave. First, heart rate, I think we already know that basic thing is that you divide 1,500 by the RR interval in small divisions. And it's a very interesting, one interesting point I want to tell you is that the heart rate increases from day 1, reaches a peak at 4 to 6 weeks. Usually, I used to believe that the fastest rate was in the day 1, but it's not so. The fastest is the somewhere around the first month of life, then remains static for up to 6 months and slowly, progressively declines. So we know basically how to calculate the heart rate, which already has been mentioned by Srinivas. And we must also grossly, at least, there are charts, but practically in an OPD, we should know whenever a newborn has a rate of more than 150, infant more than 120, and older child more than 100, you're talking about a tachycardia, whereas bradycardia in the newborn will be around less than 90 per minute. Infant, it will be 80 per minute, and the child, of course, adolescent, will be just like an adult of less than 60 per minute. And sometimes the newborn heart rate can vary between 120 to 200. But we must remember that it almost never exceeds. Sinus node in the newborn is not capable of producing a rate more than 220. So you must think of a supraventricular arrhythmia. Now the rhythm, basically what we need is a sinus rhythm. In a sinus rhythm, as you know very well, P wave is upright in 1, 2, 3, and AVF. And the P wave is inverted in AVR. Here you can see the P wave is inverted, upright in lead 1 and negative in AVR. This is the advantage of this kind of ECG, that is a 12-lead ECG, which we all should be having, is that 1 and AVR neighbors. So you can easily compare P in 1 versus P in AVR. It's very easy to see whether the person has got a normal sinus rhythm. Now we look at the P wave. We must look at lead 2 and V1, which show the best of P waves. And we should look at the width, the height, the morphology, how does it look like, the polarity, and sometimes it can be absent in atrial fibrillation. And the P wave height normally is less than 2.5 millimeter in lead 2 and less than 1.5 millimeter in lead V1. And the width usually is less than 110. So which means that if there is a width of P wave more than 3 small divisions, it is definitely abnormal. We are talking about an enlargement of this. Sometimes what happens is that the P wave in lead 1 is inverted and in AVR is positive, which means you're talking about a potential situs inversus. Now, inverted P wave in lead 1 need not always be due to situs inversus dextrocardia. It can be due to a technical error, or it can also be due to a left atrial rhythm. Now we look at the chamber enlargement, what we call as the atrial overload or enlargement. 3 important practical things is that you have the right atrium. P wave amplitude is the important, more than 2.5 millimeter in lead 2 and more than 1.5 millimeter in lead V1. You can see here a peaked, only positive wave in V1 and a genuinely peaked P wave in lead 2, which indicates that you are dealing with a right atrial enlargement. So this here again, you can see a tall peaked Gothic kind of P wave, which shows right atrial volume overload. Then the left atrial enlargement by duration as well as the notching, as you will see here. You have a biphasic P wave in lead V1 and a wide biphasic P wave in lead 2. And sometimes you will have both right atrium and left atrium. This indicates the left atrial enlargement, whereas this indicates possibly a right atrial. So you have a biatrial overload. Now we come to the fourth portion, the fourth commandment, I would say, the PR interval. This is basically from the beginning of the atrial depolarization to the beginning of the ventricular depolarization. And it is measured from the beginning of the P wave to the beginning of the QRS complex, as you know very well. So very simple things which we already learned during our MBBS days. And of course, depends on the age also. So we should know what is abnormal or what is normal at various ages. For example, if the PR interval is more than 145 millisecond, it is abnormal in a newborn. In infants and children up to 16 years, anything above 180 would be considered abnormal, and anything above 200 in an adult will be considered abnormal. And what is meant by a short PR interval? That is less than 2 small divisions, that is less than 80 milliseconds. And then we come to the QRS width and morphology. This is the width which should be measured from the beginning of the Q wave to the end of this. And this can be narrow or wide. Now here is a very, very important practical problem, especially when we go analyze arrhythmias. What is meant by a wide QRS? Because what is a narrow QRS in an adult may be a wide QRS in a small infant. For example, definition of wide QRS in a newborn is only 2 small divisions. Wide QRS in infants more than 90 milliseconds. Wide QRS in a child, it is more than 100. Whereas in an adult, wide QRS means more than 110. So this is very important to understand what is meant by a wide QRS tachycardia or a narrow QRS tachycardia in small children, because depending on the age, they have different kind of cutoff. And we know the usual causes of a wide QRS, starting from ventricular ectopics, WPW syndrome, bundle branch block, electrolytes, and various aberrancies. A right bundle branch block can be found in children, extremely rare in the newborn. Whereas LBB, which is very important in an adult practice, is extremely rare in infants. So this is the RBB here. This is the right bundle branch block. And now we have the left bundle branch block, which is rather unusual in pediatric practice. Then in addition, they can have a bifascicular block and a trifascicular block. Now we should look at the what you call as the morphology. There are different kind of morphology. You have an RSR pattern, you have a RS pattern, you have a tall R and a small s pattern. Different kind of pattern can be found in various kinds of ECG, which you will see regularly when you start reading the ECG. And this aspect, I'm very happy. It's very good that Srinivas did this. They has divided this into the thumbs up thing, normal, right axis, left axis, and right upper quadrant axis, which is what is called a so-called indeterminate axis. And this is a repetition of Dr. Srinivas. Simple thing, again, I'm just going through it. That is 1 and AVF are positive. Thumbs up, both sides, normal. If 1 is negative, AVF is positive, it is right axis. And if 1 is positive or AVF negative, it is left axis. Both are negative, it is a right upper quadrant axis. Now we must know that in the newborn, right axis is normal. And another very interesting thing is that most abnormal heart in infancy will also have a right axis, and especially if it is more than 135. But what is more important is that in a small infant, an unusual axis like a left axis and right upper quadrant axis are more useful than others. This is an abnormal axis in the newborn. It is beyond 150. left axis is definitely abnormal. In a child, right axis beyond 120 would be abnormal. There should not, the left axis will be less than 0 degree. Whereas an adult, left axis up to -30 can be taken as normal. Now, look at this. This is very simple. 1 and AVF are positive. We know from Srinivas that this has to be a normal axis. If 1 is negative here and the positive AVF is there, we know that this is a right axis deviation. And this is 1 is positive and AVF you can see on the right side, on your right side, which is negative, which means you are dealing with the left axis deviation. And the last is 1 and AVF both are negative. It is called a right upper quadrant axis, which could be an extreme right axis or an extreme left axis. We will not go into that detail. So this is all basically repetitions. For example, look at this. This is lead 1 is positive and the AVF is negative. So it has to be left axis. Here it is 1 is positive and the AVF is positive. So which is a normal axis. Here 1 is negative, AVF is positive, right axis. So it's comparatively very easy to cover. Don't bother to make it into 110 degree or 15 degree, etc. It's enough that you decide whether it is so-called normal, right axis, left axis, and right upper quadrant axis. Now we have the R by S ratio in the ECG. This is very important, very, very important, especially in V1, because it varies with age. R by S in infants and young children is usually more than 1, whereas R by S in adults is actually less than 1. This is very important. For example, this is a patient, day 1, the first day of life of a baby. You can see in V1, we have what you call R is much definitely taller than the S wave. This is day 2, same thing, R is taller than S. Now this is again V1 taller than. So this is day 5. Day 5 again showing a prominent R wave, positive wave. Day 10 continues like that. Now look at 8 months, still R is taller than S. Whereas by 3 years, suddenly what has happened is that R is smaller than S. So somewhere around 3 to 4 years, as Srinivas was saying, it becomes an adult-like pattern where R is smaller than S. So in 9-year-old, definitely we expect R to be much smaller than the S. So now the next is the R by S relationship in precordial leads can be useful in some ways. For example, if you have a progressive decline of a R wave in V1 to V6, you should suspect a dextrocardia. And suppose you have a very small R and a deep S in all precordial leads. In a cyanotic child, we should think of a single ventricle. And there's one kind of right ventricular hypertrophy due to cor pulmonale, which can produce small R and a deep S in all precordial leads starting from V1 to V6. Now the transition, the postgraduates are always asked about this transition, early transition in tetralogy of Fallot. Normally, the polarity of the QRS complex changes at somewhere around V3 or V4 mid precordial leads, as you can see here. Here, lead V1 is strongly positive, V2 is positive, and becomes slightly negative in V3. So the transition has occurred at V3, which is absolutely normal. Now look at your right-hand side. V1 is only monomorphic positive, but suddenly the polarity changes. That is what is called as an early transition, very classically found in tetralogy of Fallot. But you should remember that all tetralogies need not have this early transition. Now, I have given a text material to Manish regarding the exact criteria for ventricular hypertrophy and atrial enlargement, but we will just touch upon this. The RVH can be systolic overload or diastolic overload. And there are various criteria which have been given in that word text. But what you should know is that there is an RSR pattern in V1 indicates a volume overload, whereas if you have a monophasic R wave in V1 indicates a right ventricular hypertrophy along with the right axis deviation. LVH, I think there is a Loyon-Sokolow criteria separately for children. There is a criteria for adult, there is a criteria for children, which we should know. And this is an example of a very tall R wave in V4 to V6 with the ST changes and T inversion, which indicates a pressure overload like in aortic stenosis or coarctation of aorta. Whereas if you have a tall R waves, tall T waves, Q, deep Qs, you should think of a volume overload situations like an MR or a patent ductus arteriosus. And of course, we are all fond of this. Examiners are also fond of this. That is called Katz-Wachtel phenomenon. That is, you combine R and S in mid-precordial leads. If it is more than 45 millimeter or more than 60 in an infant, you call it as a Katz-Wachtel phenomenon. This is a classical one where, basically what is happening is that the R and the S overlap each other, so that there is definitely a Katz-Wachtel. Then we come to the ST segment. Again, Srinivas has mentioned this isoelectric ST segment and the juvenile pattern he has shown you. And I will only show you the ST segment elevation, different kind of ST segment elevation and all those things. And then different kind of ST depression like upsloping, horizontal, downsloping. But somehow these things are relatively less common because it is more often associated with the coronary artery disease. But you must remember that you can have a coronary artery disease like a Kawasaki or an Al-Kappa in pediatric practice also. Now we come to the T wave. This is very, very important. I think frequently it has been highlighted by Srinivas also. Frequently upright in a term newborn baby becomes inverted by 5 to 7 days of life. So basically, there are negative T waves persist up to around 7 years. So you can easily remember like this. No, it becomes inverted by 7 days and it remains there till 7 years. So you can say an upright T. This is very important. An upright T in V1 between 7 days to 7 years may indicate a right ventricular hypertrophy. It's very, very important to know. And so this is the standard thing, normal from 4 days to childhood. T inversion in V1, V2, V3 are normal. Upright T in V1, that kind of child is abnormal. It's indicative of a right ventricular hypertrophy. And this is a T inversion which is found in V1, V2, V3. So this is normal. Whereas here, everywhere from V1 to V6, there is a T inversion with an ST segment depression. So this has to be abnormal, possibly indicating a right ventricular hypertrophy. Now, this is another one which again Srinivas has mentioned, QT interval. This is very important because it has to be measured either in lead 2 or V5 or V6, where you find a nice ending T wave. And the two standard deviation above mean would be approximately 440 milliseconds. That is why we take this value as an abnormal value. You can calculate from the beginning of the QRS complex to the end of the T wave. That is a regular QT, and it is measured by the Bassett formula. That is QT in millisecond. That is what very important to know, that QT in millisecond, like 800 or 600, 360, divided by the square root of RR interval in seconds. For example, it usually comes as some 600 milliseconds. So it is actually 0.6 seconds. So that is the value you should get. And normal is less than 0.44. Borderline is up to 0.46 and definitely abnormal above the 0.46 business. This was actually a boy who was referred to me as a bradycardia, complete heart block, but he has only sinus bradycardia, and you can see that the QT is so prolonged, and you can see here it is measured as 480, which is definitely abnormal. So it's a QT interval. The sibling also had this one, so basically they were suffering from a long QT interval. Then the others, basically the rest, for example, Srinivas spoke about the clockwise loop and counterclockwise loop. When I was a postgraduate in pediatrics and joined Chitra as a DM candidate, this clockwise loop and the counterclockwise loop, I think it was something alien thing, but it is very simple as Srinivas mentioned you. That is, if you have Q wave in one end AVL and no Q in 2,3 AVF, it's called a counterclockwise loop. Whereas if you have a Q in 2,3 AVF and R in one end AVL, it is called a clockwise loop. This is very important in congenital heart disease and vesicular blocks. For example, this was actually an ECG of a primum ASD with the left axis. You can see the left axis here, and there is a Q in one and AVL. So this is a counterclockwise loop. Whereas this was another child who had a Q in 2 and 3 and AVF, no Q in 1 and AVL. So this is a clockwise loop. So this is also important in certain congenital heart diseases. So finally, at the end of the day, the kind of reading, the 10 points you should know is that rate in this patient, I would say 100 per minute. In sinus rhythm, why? The neighboring, you look at the neighboring, lead 1 and AVR. Lead 1, P is positive, AVR, it is negative. So it is a sinus rhythm. Then you look at lead 2, a peaked P wave, that is right atrial enlargement. Then you measure PR interval, it is around 160 millisecond, which is normal. Now look at the QRS width in V1 precordial leads. They are normal, so it's a normal QRS width. But look at the axis, lead 1 is negative, AVF is positive. So which means you are dealing with the right axis deviation. And the morphology, look at the morphology very carefully, and you will find there is an RSR pattern here. So this is an RSR pattern in V1. So 3 most important points. Then ST segment is normal, T is inverted from V1 to V3, which is expected. QTC is normal. So 3 highlights are the RA enlargement, QRS axis of right axis, and an RSR pattern. You basically make a diagnosis of a ostium secondum ASD in a child with some asymptomatic murmur or a wide split second sound. So we must remember that the ECG is not as mysterious as a event horizon or a black hole. And we must, because we all these pediatric cardiologists, we know that how difficult it was for us when we started doing our DM or a subspecialty training, because our colleagues were invariably internal medicine people who had a much better idea of ECG, whereas we were a little scared. But slowly, I think you come out of that fear complex, and that we should do. Not only pediatric postgraduates, but also pediatricians should be comparatively comfortable with the electrocardiography. And thank you very much. I'll be glad to answer any chats in the chat box, probably directed to me by Munish. And thank you very much, my friends and the young knights.
Thank you, sir. Yeah, thank you, sir. Very nice presentation. And Srinivas and Zulfikar, sir, just covering the basics and how to read an ECG. And most important point here, I would say that pediatricians should start looking at the ECG. So whatever we explain, if we don't regularly see the ECG, it's difficult to get all these things absorbed into our mind. Because listening and then applying is the thing to add these things.
Even the so-called normal ECGs, what you see, yes, you should try to read. That is what
reading and writing your comment is must.
You must.
Like Professor Savitri Shrivastava, she used to ask write comment about every ECG. Whatever you see means in all patients we have to, without notes, she was not taking the round. That was the from her side order. So that made us so fixed about this writing and signing. Writing and signing was compulsory in her round. There were many questions. Srinivas was answering majority. There was one question related to premature preterm baby ECG. So Naveen was asking, it depends on Naveen which age of gestation we are talking. Less than 32 weeks, it is LV which is dominant. After 32 weeks, it's slowly RV takeover. So that is the transition roughly happen in preterm ECG. So extreme preterm babies may show, will show obviously more of LV than RV. Then in a usual 32 weeks onward and term baby, we have RV dominance in that. There's QTC and everything answered by Srinivas in the chat box. And it is good to see so many people are putting their queries. It is important that they are interacting into it. And it's because of Srinivas make it so basic, so clear, and so added on that. So to develop their interest. And now I think they should have an ECG machine and start doing ECG. Reading ECG is important.
How many of you will start doing ECG after today's session?
At least many should read.
Yeah.
See, there was it's a very interesting. One of my postgraduates, some 20 years back, had a habit of. He was in the casualty ER. There was a diarrhea training unit in our SAT hospital. So he was on for 12 hours. He's only diarrhea patients. Very unexciting. So what he did was he started doing fundus examination of all children, and by 2 weeks he became so proficient in ophthalmoscopy. Similarly, every ECG you see, normal ECG, adult, for example, in Kim's hospital, the ECG room is shared by both pediatric and adult. So even adult ECG, we should promote the PG to read the ECG continuously, even if it is normal. So finally, it becomes very easy. This 10-point formula, I think, is going to be useful.
That's what I tell my residents: just go and ask adult guys, because you have to make them friend to learn ECG in totality.
Exactly.
For us, findings are different. For them, it is they just start with MI things, and we start with the rate and access. So reading means mind accordingly work, but it's better to see all type of ECGs because a child can come with MI, or their patient can come with the congenital heart defect. So all the department, especially medicine and pediatrics, it is important for pediatric cardiology and adult cardiology to have a complete discussion about these ECGs for the students especially.
Yeah, when you start reading an ECG, there are two components for reading an ECG. One is reporting an ECG. So what Zulfikar sir has also stressed. Report on point number 1 to 10. Report the entire ECG without any bias. Okay. So once you report an ECG, after that, interpret an ECG. Okay. So let us say you have 2-3 abnormal points out of these 10 points. Then you interpret an ECG. Do not start with interpretation, then you will miss out on very important points. Okay. So start from point 1, 2, 3, 4, 5, 6, 7, 8, 10, write down everything, and then you give your interpretation of this 10 points. That is how you report an ECG.
Exactly.
If you develop this habit of reading an ECG, even if you make 10 out of 10 mistakes in the beginning, it's okay. But you will improve eventually.
Yeah, I think that is a wonderful thought. I think that is the thought we should drive you. I think probably the most important take-home point, I think Srinivas just said. I think it's very, very important.
Yeah, one comment is there on automatic reading of ECG. Please do not read automatic ECG.
Yes.
Okay? They are not at all reliable. Okay,
And
so read for yourself. In pediatric, they are not standardized.
Especially in the newborn, I think they are not reliable. And because many of the ECG machines are standardized to adult values, so they will tell you LVH or RVH or MI and all those things. So be very careful. Ischemia, anterior wall ischemia and all. And people get scared. So I asked the educate, because in Kerala, it's a difficult task, because we have very high literacy and little less education. So they get carried away by the electronic interpretation. Yes.
So there's a way to disable that report also. If you want, you can actually disable
I see.
in your machine not to give that
Not to give that
interpretation by the machine. Any other questions that we have to address, Dr. Manish?
Manish, I think
we have answered.
Yeah. You are anyway giving our presentations,
Yes, sir.
To them, because
yes,
there's no barrier. You can make it PDF or your PowerPoint, anything, whatever you want.
We will give this presentation in soft copy, in a PDF format.
Okay, whatever format, or text material, whatever. Because this is purely sharing our.
And the questions which you share with me and other speakers, I will share with them during the offline session. We'll discuss with them.
You're doing a wonderful job. Really.
Thank you, sir. Thank you, sir. And thank you everybody for joining the session, and thank you Ajay sir and IAP, Central IAP, everybody, because these sessions are very important. We have to keep on doing this stimulation activity to like increase interest of the pediatrician into the cardiology. Whatever the disease the child is carrying, heart is affected. Whether it is heart rate or it is function, some way a heart is getting affected if child is sick. So we can't leave a heart to the pediatric cardiologist. The pediatrician have to understand the heart, and just from our side, we do small efforts just to make them comfortable with the heart. That is the only thing.
Dr. Ajay, I think you are the UPIAP. I think it's a wonderful job, and it is really
Thank
from
you,
my
sir.
heart.
Yes, sir.
So we are all there to help you out. Anytime,
Thank you, sir.
anytime Munish calls us, me or we are all
Thank
ready.
you, sir. Just I would like to share with you that in this year we had tried to do this hybrid certification course in pediatric diagnostics, which are less often touched in our medical curriculum. Like first we had our EEG course, then we had our liver mirror, and this is third in this series, and probably one more, that is complete blood count, will be taken somewhere in the last of this year. And all the programs were 5 days online and 1 day offline with hands-on, when we had all the demos and all. So in this session as well, Dr. Munesh has planned to do some real hands-on. She will be bringing one DFib and ECG machine and all demos. So I think that will be a wonderful thing. So let us see how it goes. And thank you very much, sir. We have crossed our time, and tomorrow the same time, same place. Till then, bye bye.
Thank you. Bye bye. Take care. Bye.
Okay.